Hello everyone, welcome. I'm Dr. Sharif Al-Halim and today we're going to talk about pheochromocytoma. So, pheochromocytoma is actually a tumor which arises from the adrenal gland, specifically from the adrenal medulla. So, in the adrenal medulla, you have the chromaffin cells. Those chromaffin cells sometimes can get abnormal proliferation, leading to formation of a tumor known as pheochromocytoma. And the chromaffin cells can either be proliferating in a way that it's benign, or sometimes the cells can be dysplastic or anaplastic and can lead to a malignant proliferation. So there is a very important rule of 10 about pheochromocytomas that you must know. And number one, and one of the most important, is 10% of the pheochromocytomas are malignant. So pheochromocytomas can either be malignant in 10% cases, and in 90% cases it's a benign tumor. And in 10% cases it can be bilateral, involving both of your adrenal medulla. And interestingly, 10% of the cases can be extra-adrenal. And some of the common sites are bladder wall or organ of Zucker candle at the inferior mesenteric artery root. So those are the common sites of extra-adrenal pheochromocytoma. And 10% of cases can calcify, and 10% of those pheochromocytomas occur in kids, and most of the pheochromocytomas actually are found in adult population. So clinical features of pheochromocytoma are very important because it's a very common question in standardized examinations or licensing exams. Very important to know. So the clinical features actually depend on the secretion of epinephrine, norepinephrine, and dopamine from the abnormally proliferating chromaffin cell. So the level of those hormones gets up, and this occurs. This increased level of those hormones or chemical substances occur in an episodic manner, and the main action of those chemical substances are on the cardiovascular system, especially on the alpha-1 receptor. They increase the vasoconstriction, and that's why increase the total peripheral resistance, increasing blood pressure. So episodic symptomatic hypertension is the classic manifestation of an adrenal tumor or pheochromocytoma. It's very important to know. And the pheochromocytomas are commonly associated with some disorders, very important. One is neurofibromatosis type 1, very important to know. Another one is von Hippel-Lindau disease. And most importantly, I think MAN2A and MAN2B, very important to know. So very, very important. Please note that. And the symptoms of pheochromocytoma occur in spells or episodes, and the patients sometimes are totally well and sometimes they get totally unwell. So the patient have a relapsing, remitting course of the disease. And the patient during episodes, they get something called episodic hyperadrenergic symptoms, which are which can be memorized by remembering 5 P's. So one of the most important P and most common findings in the typical clinical scenario is raised very high blood pressure. Very high blood pressure. It occurs due to increased secretion of those substances. And this high blood pressure actually can lead to headache. And there are some other features which are due to manifestations of other receptor activation. So the patient can get sweating. The patient can have palpitations because you have the beta-1 receptor in your heart, which will be stimulated and can cause palpitations. And the patient can also have pallor. So diagnosing pheochromocytoma is a very easy thing. You have to just do a few laboratory tests, and one is you have to do the serum catecholamine levels, and more importantly serum metanephrines, which will be elevated. And most importantly, you have to collect a 24-hour urine sample and look for metanephrines and vanillyl mandelic acid, which will be elevated. So very important to know. And main treatment actually is resection of the tumor, but there are some precautions that you must take. So one thing is, whenever someone is manipulating the tumor may leak some excessive amounts of catecholamines into the circulation, which might lead to a hypertensive crisis. So to avoid this fearsome effect, what you must do is first give the patient some irreversible alpha antagonists like phenoxybenzamine, followed by beta blockers prior to tumor resection. And importantly to note, alpha blockade must be achieved before giving beta blockers, because if we don't block the alpha receptors and just give the beta blockers, especially the beta blockers will block the beta receptors, and now alpha receptors are unopposed, so the norepinephrines and epinephrines will specifically bind to the alpha receptors and can cause a hypertensive crisis. So very important to know, you have to give alpha blockers before giving beta blockers. So here you can see pheochromocytoma inside the adrenal gland, so in the medulla, the whitish area, and it actually involves the medulla. And now you can see some histopathologic pictures of adrenal medulla, and you can see some big nucleus which are actually polymorphic. It's typical of malignancy, so it's the uncommon variety, or it's of the 10% cases and malignant, and it's a case of malignant chromatin cells and malignant pheochromocytoma. So that's all from me today about pheochromocytoma. Thanks for watching my video, and correct me if I am wrong in some ways.